If you have a question, please pop it in the chat box and we will be monitoring it. The seminar will be recorded. Please do not try and record the seminar yourself. And now I'll hand over to Dr. Sharma. Thank you very much.
Thank you all so much. I'm really looking forward to chatting with you all. I'm just going to pull up my slides and get started. All right. Can everyone see that okay?
Yes, we can. Thank you.
All right. So thank you so much for that kind introduction. I'm super excited to talk about this topic with you all as we think about something that is particularly important for the populations that we serve. Just wanted to acknowledge some of the funding sources for my own work here in the US and give you a sense of what I'll be talking about. So I'm going to start by just describing these terms: limited English proficiency, preferred language other than English, and just give kind of a brief overview of some of the demographic characteristics, who we mean when we're talking about these populations. Then I'm going to briefly review some of the data on the inequities that this population experiences. And then I'll spend most of the time talking about an intervention that we have within our healthcare system that moves beyond access to language services, called the CCM program, as an example of the type of multi-level intervention that I think is really needed to improve care for these populations. And then I'll just kind of spotlight a little bit of our current work as we are working to develop additional interventions for this population and chat about some of the considerations as we think about working with these communities, and particularly in the context of palliative care research. Okay, so I think this will resonate with you all, but given the central role of communication in the care of patients with serious illness, those who have limited English proficiency are going to be at high risk for experiencing inequitable care, and thus an important population for us to be thinking about as we provide this type of care. So what do I mean by these terms? So in the US, the US Census defines limited English proficiency based on this question: how well does this person speak English? These are the response options. Less than very well signifies limited English proficiency. This question is similar to the one that is in the UK census, and I'll show you UK data in a couple of slides. In the healthcare system context, though, we are generally not assessing people's proficiency. We are asking rather about their preferred language. Here's the question that we ask within our own healthcare system, which is: in what language do you want to talk to your healthcare team about your care? For us, the default is unknown, not English. So you have to specify a language, including English. And for those who specify a language other than English, that can be another way to kind of get at this concept of limited English proficiency. There was a study done in San Francisco at UCSF that compared these two questions. So if we ask people about proficiency and we ask people about preferred language, are we capturing the same population? They were looking specifically at those who spoke English and Spanish, and inside this red box, you see everyone who would be considered to have limited English proficiency based on the proficiency question, right? Speaking English less than very well. What you'll see is that everyone who stated a preference, a preferred language for Spanish, is captured in this proficiency bucket. At the same time, there are a relatively small number of patients who reported a preferred language of English, but also proficiency level less than very well. You can think of reasons potentially why someone may hesitate to say that they have a preferred language other than English. The point, I think, here is that in general, these two questions are mostly getting at the same population, but highlighting that there are some subtle differences when we ask about proficiency versus preferred language. And that gets me to another point that I want to make around terminology. So in the US literature, for sure, I would say that up until recently, we have used this term limited English proficiency, even when we are talking about data that is coming out of the healthcare system. Recently, particularly in the pediatric world, there's been a push away from that term, feeling that that term is really positioned in a place of deficit. And what would be more accurate, again, especially as we're talking about the healthcare setting, is using terms like either non-English language preference, which I have not actually seen get much traction, or the term that I'm seeing more and more, and also trying to use more and more, is preferred language other than English, which I think is a more accurate representation of what we're talking about. For the most part, I'm going to try to use that term throughout this presentation. I will use the LEP term when I'm talking about census data or other studies that really used that term. Okay, so wanted to give you a sense as you look at demographic trends in the UK and the proportion of the population with limited English proficiency. Again, this is a proficiency question that is coming from the UK census. You can see that the proportion has actually been relatively stable between 2011 and 2021. So it's those bars that are on the bottom half of this graph that are showing the proportion of the population that reports speaking English less than very well or well. In total, the adult population, based on the 2021 UK census, is just over 1 million individuals who report limited English proficiency. This gives you a sense that there are some differences in limited English proficiency proportions based on region of birth. So you can see in the dark blue bars, that's the proportion of the population coming from different parts of the world whose primary language is English. The teal bar reflects those who have a primary language other than English, but have high levels of English proficiency. And then that kind of pinkish purple bar is signifying the proportion of the population with limited English proficiency, again, coming from these different regions around the world. And we can zero in a little bit on the most commonly spoken languages in the UK. Again, you're seeing a shift in some languages over the last decade that, at least in part, is driven by differences in migration patterns and kind of our political landscape. So you can see, at least as of 2021, the top 2 languages are Polish and Romanian, as we look at those who speak a language other than English living in the UK, followed by several languages from South Asia, Punjabi, Urdu. You see some languages towards the bottom, Portuguese and Spanish and Arabic there in the middle. Again, you see a really marked rise in Romanian over the last decade. So that really stands out as you look at some of the breakdown in languages. Just to give you a sense of how does that compare with the US, so we have more than 25 million individuals with limited English proficiency based on our more recent US Census data. The most commonly spoken languages are there on the left. And on the right, you're seeing the proficiency breakdown by language. So the orange, green, and purple bars are reflecting those with limited English proficiency. And you can see that when we look at these 5 languages here on the bottom, which are also some of the most frequently spoken languages, or the largest populations in the US, that for some of these populations, more than 50% report having limited English proficiency. So again, as we look at our landscape here, really highlighting the importance of thinking about this population as we think about ways to improve care and what populations may be underrepresented in research, particularly as we think about serious illness. Okay, so now I want to move to looking at some of the data about the quality of care as we think about those with limited English proficiency or preferred language other than English, specifically in the context of serious illness. There have been many studies that have documented across illnesses, across settings, that patients with preferred language other than English experience disparities in multiple areas. Those include having suboptimal assessment and treatment of symptoms, having unmet informational needs, so not being informed of or not understanding such important things as diagnosis, prognosis, treatment plans, side effects, available resources. Now, of course, you can imagine having unmet informational needs makes it really hard to make informed decisions. So we see disparities in informed decision making. And all of these things leave patients and their families feeling vulnerable, disempowered, frustrated, and having difficulty communicating, again, important things like experiencing adverse effects. Even in systems that have more robust interpretation services, there may still be a lack of interpretation services in some key patient-facing areas, places like patient registration, pharmacies, even in operating rooms. When we look at the context of end-of-life decision-making specifically, this is a study that was looking at patients in the ICU. You can see kind of the breakdown of the language distribution for this particular study. And they found that patients with limited English proficiency were more likely to receive mechanical ventilation and have restraints used at the end of life. They were less likely to change their code status from full code to do not resuscitate. When they made that change, it took longer. They were less likely to receive comfort measures at the end of life. And again, it took much longer, to transition to comfort care when that happened. And then they were much less likely to have completed advanced directives or advanced care planning, as we see with many other minoritized populations. These are data from Canada showing a similar pattern of higher intensity care at the end of life for immigrant patients. So here they were looking at what they called recent immigrants, which were those who had immigrated after 1983, just to give you context. But in the last 6 months of life, those who had more recently immigrated were more likely to have hospitalizations, ICU admissions, mechanical ventilation, dialysis, PEG tube placement, tracheostomy. So again, a consistent pattern of higher utilization of these higher intensity interventions at the end of life. And this was among a decedent population. To note, on the map, you can see that there is some variability by geographic region in terms of the relative risk of dying in an ICU. You can see, for example, the highest blue is actually over South Asia, as well as parts of Africa. Closer to home, we looked at data within, again, our own healthcare system among older adults with serious illness and limited English proficiency. And we found that for that population, they were more likely than those with English proficiency to have 30-day readmissions, emergency department visits. They were more likely to die in the hospital, and they were less likely to have completed advanced care planning documentation. Now, I think an important piece of the puzzle as we are thinking about these patterns of high intensity care or high utilization of care are that what we don't see are the role of patient preferences and values, right? So I think it's an important distinction to make about whether people are choosing certain interventions, and that's reflected in these data, or if things like suboptimal communication, mistrust are actually driving some of these utilization of care patterns. And that's difficult to disentangle when we look at electronic health record data, right? It's harder to understand what people's preferences were. But I would highlight that for me, a key takeaway from these data are actually around targets of intervention. And as we think about interventions to improve care for these populations, I think these data highlight that the hospital setting is one important place to be thinking about as we are developing interventions. So that's a point that I want to highlight is given these patterns, again, trying to understand what's driving these patterns is one important course of research. But the other piece is recognizing, okay, here's a place where people are coming for care. How do we make sure that we are intervening and supporting them in this setting? So why are we seeing some of these patterns and why are we seeing some of these inequities that this population is experiencing? Well, one of the key reasons for that is the underuse of interpreters or barriers to access to language services. In these data that we're looking at patients that were hospitalized, you can see that at the time of hospital admission, only a full 43% of patients did not have an interpreter of any kind present in their conversation with the physician. So that's including no professional medical interpreter, no family, friend, other healthcare staff member, no one. 40% of patients did not have an interpreter present when they were having conversations with their physicians during the hospitalization, and 63% had no interpreter present when they were having interactions with nurses, again, during the hospitalization. And in work from the same group of trying to understand what is driving this lack of use of interpreters, from some qualitative data, we get some insights about barriers, including time constraints, and this idea of just trying to get by, right? Here, this resident saying, I know that when people are very pushed for time, they may or may not call an interpreter. They may just get by on the few words they know in different languages for like pain and take a deep breath and just kind of fumble through. What I think is more worrisome is illustrated in this second quote, which is the idea that we know we are doing a disservice to patients when we are not ensuring that interpretation is present. Here, this resident saying, I feel guilty because I feel like I'm not doing my job. It also makes me feel very frustrated and upset at how our hospitals and clinics are run. We allow this to happen. There's a lot of sentiment that, well, maybe patients with LEP shouldn't be getting health care. I think the reason that I feel badly is because I know that I'm not giving equal care to my patients. So again, really highlighting that we know equitable care requires basic things like access to language services so that people can understand what is being said to them and be able to communicate back to their healthcare providers. But because of some of these system level constraints, we're not delivering on that promise. Okay, so one piece of this is not using interpreters at all, but even when we do involve interpreters, there's still inequities in the quality of communication that is happening. Here's data from Australia, where they had recorded conversations between oncologists and immigrant versus native-born patients with cancer. 23% of physician prognostic statements were not interpreted in the presence of an interpreter. 27% of interpreted statements were not interpreted accurately, and 59% of patient family prognostic statements were not interpreted. To give you an example of some of the alterations that happened in interpretation in these recorded discussions, here's one example, the physician saying, we think there's a 40% chance that the treatment will prolong your life. The interpreter changes that to, the treatment will prolong your life. So this important piece around the 40% chance dropping off in the interpreted statement. Another example, physician saying you have a reasonably good chance to respond to the chemotherapy, and therefore I should be able to control this cancer for months and months. The interpreter saying, but you have a great chance if the chemotherapy works, the disease, your life should be able to be prolonged and prolonged, right? That reference of months as a prognostic statement, again, missing from what is being interpreted. In addition to these alterations that are happening in interpretation or gaps in interpretation, they also found that oncologists changed the way they were communicating in the presence of interpreters, actually using more jargon with patients when interpreters were present, and they made fewer statements of hope. So again, here wanting to underline that one issue for sure is being able to have access to interpreters, but even when interpreters are present, we still see gaps in care. So making this point, interpretation in all settings is fundamental, but many gaps still remain as we think about the care that patients in this population are receiving. Okay, so now I want to kind of move from having made this case that this population is experiencing a wide range of disparities in the quality of care to trying to think about multi-level approaches and targets for intervention. So I want to tell you about a program that we have that I think illustrates some key strategies in improving care for these populations. And this is our CCM program. CCM standing for Caseworker Cultural Mediators. The program was actually started in 1994, so we have had this program for a long time. It's been hard to grow the program, which I would say is an illustration of some of the system level constraints. The program originally having 5 to 6 CCMs has now grown to 10. So it represents the following languages: Amharic, Cambodian Khmer, Vietnamese, Somali, Spanish, and then we had an influx of refugees from Afghanistan, and so recently added Pashto and Dari languages. So the CCMs are full-time hospital staff who are also embedded in the community. So they actually get time provided to them to have a role with a community-based organization, to be delivering educational content in the community, to be actively working in the communities that they are from, in addition to being fully embedded within our healthcare system. And the mission really of this program being to contribute to the health of refugee and immigrant patients, families, and communities through partnerships that promote culturally sensitive and health equitable care. So we did a qualitative study where we interviewed the CCMs, clinicians who referred patients to the CCM program, and patients who received care through the CCM program to try to understand what were some of the key elements of the services that the CCMs were providing that was really integral to the care that was received. And we identified a series of tasks, which I'm going to go through and give you some quotes to give you a fuller sense of the work that these CCMs are doing with these patients. Okay, so two of the first tasks that emerged in our qualitative data were around advocacy and education. As we think about the advocacy bucket, it means things like the CCMs prompting clinicians to provide patients with more information. So right away, you can see a difference between what services an interpreter provides and what services the CCM, who is also providing interpretation, provides instead. Encouraging patients to ask questions and disclose truthful information to clinicians, recognizing the need for connection to other services. Here's a quote to kind of give you a sense of how that advocacy plays out, and then I'll move to education. So here is CCM saying, advocating, especially being their voice when I see that something is not going the way it is supposed to be in the healthcare system. This is, I think, a key piece around the CCM program that I think makes it a little bit different than some of the other community health worker or lay health navigator type of interventions. which is because the CCM is fully embedded within the healthcare system, they're better positioned to recognize when care is not going how it should be, right? So I think they can better identify when inequities in care are happening because they are so experienced with understanding how the healthcare system works and what should be happening. And so in this case, then being the patient's voice when they see that something is not going the way it's supposed to. And then this example from this clinician saying, I think that they felt, the patient and family, once we had the CCM involved, that they had an ally. They had someone that spoke their language. They had someone that understood their customs. They had someone that was advocating for them, right? So this one person that they felt they could turn to that was hearing their concerns and advocating for their concerns. Then turning to the second task around education. So here we're talking about education in two different directions. So the CCM providing education to the clinician about key cultural values, norms, context to help better understand the patient, as well as providing education to the patient about kind of the Western healthcare system, about things like, let's say, the importance of preventive care or why we approach things somewhere. So really being this bridge, right? So again, this clinician here in the first quote in this white section, talking about a Somali patient and how the CCM was able, Somali patient with diabetes, and how the CCM was able to clue them in that Ramadan was happening, the patient was going to be fasting, and how that would affect their blood sugar levels. And then the CCM quote at the bottom talking about kind of the other side, that for patients, particularly those who have chronic disease, that the CCM, somebody they can trust, can help them understand their illness, help them to take medications, why they need to take medications. Again, the CCM highlighting here that from a cultural background, for some, the practice is to take medication only when you feel unwell, right? And so needing to shift that framing for management of chronic illness. All right. So the next two, these tasks are related, care coordination and navigation. So that spans things like identifying gaps in care, providing continuity, again, initiating resources both within the healthcare system and beyond the healthcare system, helping with the logistics of actually scheduling appointments, transportation. Now, again, remember with this population, we're talking about an additional piece around language barriers, right? So I think for many patients, navigating the healthcare system is challenging. But when you add this additional piece about language barriers, when you have to call to schedule an appointment, it is that much harder, right? You have to overcome that language piece in addition to how challenging and overwhelming the healthcare system can be for anyone. So to give you a sense of this, in this, I'm not going to read each of these quotes, but I really want to highlight this first one here, where this clinician says, I have a patient who, when she and her family came here, the CCM got them a place to live, got them stuff to have in their house, got the whole family English as a secondary language training, ESL, helped the husband get a job. I mean, helped them with all these logistics and made it possible for them to get through cancer treatment. So here's the piece where, as we think about the many barriers that patients experience to be able to access the care they need, the importance of having interventions to deal with those fundamental challenges is critical, right? In this situation, the patient is only able to engage with the important cancer treatment they need because they have shelter, because they have, some level of financial support coming in or the skills to try to build up some of that stability. So again, I think that's really the rationale for trying to think about these multi-level approaches, because at the end of the day, if we're going to make meaningful change, we need to be able to address those underlying drivers those challenges that these populations experience in order to get them to the place of that goals of care discussion or, talking about potential treatments or whatnot. And then the last three tasks that we identified were around interpretation, mediation, and emotional support. So as I mentioned, the CCMs are also providing interpretation, but it's different because they have this continuity relationship. They follow patients across settings. So that could be in the hospital, in the clinic setting, that could be doing a home visit. So there's continuity. And that continuity provides this long-term trusting relationship. They're then also able to provide a lot of help with mediation, particularly as we think about complex topics in the setting of serious illness, things like goals of care, end-of-life decisions. And then a task that really emerged that we hadn't necessarily been expecting was the importance of emotional support, where especially patients and family members talked about how critical that was when they thought about the CCM. Again, a lot of quotes here, but a couple I just want to highlight. This second quote in the first bucket, the CCM talking about we can interpret, but we can add our own to give the clinician a little bit of the background of the culture so they can help them understand about the patient. All interpreters can interpret. Our roles go beyond that to help the team understand about the patient. And then these quotes here at the very bottom around emotional support. This quote from the CCM at the very bottom here, the first full-time chemotherapy appointment, I want to be sure I go with her, right? So the CCM is accompanying the patient to their first chemotherapy appointment. After that, she talked to me, and even when I mentor her for a visa with her provider, she's crying. And she said that without our service, she didn't think that she can be where she is right now, right? So again, the importance of without that extra piece of support, this patient didn't think that they could have gotten to the point of being able to engage with treatment for their cancer. So here's a way to kind of bring together some of the findings that emerged from our work to better understand elements of this program. At the bottom, you see those tasks that I went through. Those tasks then leading to kind of 4 key impacts, right? So through the combination of those tasks, the CCMs being able to be a bridge to the healthcare team, system, family, and community to impact the knowledge of cultural issues and the healthcare system, and to troubleshoot and problem solve, and then really enhance relationship building. So those elements then enabling them to be able to address these drivers of healthcare equity. What this work also led me to think about was, okay, what can we learn from this that we can then apply to palliative care specific interventions? Can we better understand the palliative care needs of patients with LEP and their families, or PLOE? And what are some of the key multi-level targets for intervention to improve palliative care? That's going to take me to my last section of this talk, which is to just give you a kind of super quick overview of some of the work that we are currently doing in the Impact Research Program to improve care for these populations. So we have 2 current studies, one that is focused on adults with dementia, one that's focused on patients with advanced cancer. You can see the specific languages that are the focus. Those kind of map to some of the largest populations in the Seattle area and within the US who have high rates of limited English proficiency. And our 3 objectives across these 2 studies are, 1, to understand the problem areas. So using electronic health record data to identify where there are inequities in the care of patients, specifically with dementia or cancer, receiving care in our healthcare system. The second, which is where we're spending the bulk of our time, is again more qualitative work to understand the experiences and perspectives of patients, families, interpreters, and clinicians through interviews. And then the third aim that we'll be starting next year is to really understand the community level resources and gaps through interviews with leaders of community-based organizations. So again, the idea here, building off that CCM program, some of the points I illustrated there are the importance of a multi-level approach. So thinking about, okay, what are the barriers and facilitators to high quality palliative care that are happening at the patient family level, that are occurring within the clinical encounter, in the healthcare system, and then in the community setting. I'm just going to share with you a couple of early emerging kind of preliminary findings that are coming through our interviews with interpreters. So really kind of building off some of the data that I've been talking about before, but applying this multi-level lens. So we've conducted 21 interviews with interpreters and CCMs across these specific languages. As we look at the individual level, some of the key concepts that are coming up are around navigating family dynamics and a dependence on family, as well as even a broader community in decision-making and trust, right? So from a clinician point of view and from a developing intervention point of view, how do we help support patients as they have these larger networks that are often coming into play around decision making and serious illness? How do we address the cultural norms that favor more interventions? You know, one piece of what is likely explaining those patterns we see in terms of healthcare utilization. Some of the early themes in terms of clinical encounters, the need to have clinician interpreter pre-meetings, challenges around how to explain palliative care, given the additional complexity of the language barriers. So really thinking about how to do that in a way that's concrete. As we look at the healthcare system, really hearing about how early palliative care involvement is critical for these populations. And to this kind of point that I made with talking about the CCM program, this need for supports beyond interpretation. So how do we build in these pieces to help people navigate, to help promote advocacy, in addition to just addressing the language barrier? And finally, as we look at the community level, how do we increase community awareness of palliative care? Again, for these communities, thinking about culturally and linguistically appropriate resources, and a clear need to develop more resources and address barriers to accessing existing resources. Okay, I am going to I couldn't help myself, so I put a couple quotes, but I'm going to skip through those quotes because I want to get to the last two slides and ensure that we have plenty of time for discussion. So you're going to see quotes, and you're going to bear with me for a second. Perfect. Okay, so all of this work is to get us toward understanding the needs of the patients and family members. How do we support those within the healthcare system? How do we address gaps in the community? And I have two last slides. So I wanted to end on this point around how do we think about doing this research, especially as we think about multilingual populations. Key piece being building academic and community partnerships for all phases of the research. We've approached that by developing these language-focused work groups that are comprised of faculty, staff, trainees, community members, together developing all of our materials. It's bilingual interviewers from each of our work groups who do the interviews and participate in coding the data and in analyzing the data. and to make the point that when you are conducting research with multiple diverse language groups, it necessitates having large, diverse research teams. For me, this is one of the most fun parts of doing this research, but it is also challenging. Navigating a large team means many moving parts. Involving community members means there may be a lot of turnover. And so those are challenges. Training for community members. So what do we need to ensure that community members have knowledge about to actively engage with us in this research? And for our research teams, what do we need to know about? What kind of training do we need to be effective partners with our community members? And then thinking about equity in all its many forms, including things like compensation. We have community advisory boards for our study. So far, we've had bilingual members in our community advisory boards, but I'm interested in thinking about this idea. Can you expand to include those with preferred language other than English, even at this level? How do you do that when you're working with diverse populations and you want to bring multiple people together? And then my last point here is as we think about figuring out a research agenda for palliative care, it can be hard when we're reaching out to communities and asking them what kinds of questions we should tackle for people to jump to palliative care as a topic, right? We hear a lot of interest in cure cancer, help us figure out how we can get housing and address food insecurity. But like navigating a goals of care conversation is not necessarily the first topic that comes up. So that's a challenge. How do we work with communities to address the questions of importance to them and recognize that this is still a hard topic to bring up? Having said that, I would just close with how in our own experience, we have had very high levels of engagement from the communities we're working with. And I think that reflects how long they have been unheard, for how long there has been research that has not focused on trying to address their problems and figuring out solutions that work for them. And so we have found a lot of enthusiasm and excitement in our partnerships with community members. So I'm going to put up a summary slide. This is my team. It always takes a team. And put up a summary slide, and then would love to take questions and have some dialogue.
Thank you, Dr. Sharma. That was incredibly fascinating. And I can already see that Jo has got her hand up. So Jo.
Hi, thank you. It was a really excellent presentation. And as my partner comes from Seattle, it was lovely to hear somebody speaking from the University of Washington, and which is where she went to university. I was really intrigued by the discrepancies between what the clinicians said and what was translated. And it was interesting to hear the negative aspects. But did you ever find that the translators improved on the clinicians' explanations?
Yes, that is such a great question. So in another study that was looking at ICU family meetings, that actually came from the University of Washington, in those discussions, we did see incidences where the interpreter had softened something the clinician had said in a positive way. So I do think that is an important point, and it really makes me think about, can we move to a place where we are more effectively partnering with interpreters? Because I think right now it's the paradigm around kind of what the role of the interpreter is very much the interpreter is supposed to say what the physician says, what the patient says in this kind of neutral, objective way. And I wonder if there are ways where if we worked together, we could get insights from the interpreter about better ways to communicate something, and they could kind of clue us in when we're saying something that is not going over very well. So I think that is an important point. So yes, we see instances where interpreters are changing something for the better, also potentially trying to bring in some of the rapport building pieces that otherwise may get dropped.
But hopefully still
from
accurate.
Interpretation. Yes, I mean, that's the thing, right? That is the challenge.
Yeah,
Exactly.
yeah.
You're right.
Thank you, Joe. I think there was another hand up. I think it was Catherine Dilworth, but it doesn't matter if you've changed your mind. But please do unmute if you have a question. Bethan.
Just failing to unmute myself, thanks. Yeah, really interesting talk. One of the things I've struck by is the kind of patient safety stuff for people that haven't got English as their first language. And I do research with kids with complex medical needs, and not for non-verbal kids particularly, this is a huge issue. I'm wondering if you've got, any kind of useful reading around that or anything that's come out from your own research.
I mean, there's definitely research to show that, and I'm more familiar with the adult population, though there's a lot of work in the pediatric setting in the US thinking about family members with limited English proficiency or preferred language other than English. For sure, those populations are at higher risk to experience adverse events. When they experience adverse events, they're more likely to be related to communication challenges. So I think you're highlighting an important area in which there for sure is data to suggest that populations are receiving poor quality care. And I think it makes me think a lot about the role of technology. So I think in some contexts, it may be that as we've had this big uptake in access to video interpreters or in like video translation tools, I do wonder if there is a place where some of that technology could really help to improve patient safety. And when I think about palliative care or communication, I think that's a place where there's a little bit more concerns about whether that technology can be enough to navigate complex conversation. So just to make that point, that I do think that there's an opportunity to think about how technology could help address some of the inequities for this population, and patient safety may be a place where that could be particularly helpful.
Thank you, Bethan. Liam.
Thank you. Yeah, really interesting talk. It's fascinating. One of the questions I had is, it seems like your team has built up a real wealth of experience about how to communicate these different things in, numerous different languages. And I wondered if it might be something you're doing, or whether there was a way you were going to develop sort of resources for people working in other settings, so interpreters in other settings, to use as like a glossary of terms of palliative care. I remember I was speaking with someone who worked as an interpreter over COVID in Spanish in the UK, and just found that he joined and had no idea how to translate some of the things he was being asked to communicate, and there was no standardized glossary for how to do this in the UK. And I didn't know whether that was something that, with all the experience you've generated with this project, that you either were generating or had ideas to.
Yeah, great question, because actually I'm very interested in developing additional training for interpreters around palliative care. And I would say that here we have some more basic continuing education types of training that is available to interpreters. I think there are opportunities to address some of what you're talking about, things like the terminology. And I feel like there is space to really try to work on these more advanced communication skills, because it is both that we are using terms that may not have a corresponding kind of equivalent in different languages, like the term palliative care, and that those terms are really confusing regardless, right? Even to English speakers, those terms are confusing, as well as some of these terms are really emotionally charged. So I think there is space to think about training and resources, both around the terminology piece and how, again, going back to that idea of partnership, could together we better navigate what can be really complex conversations and concepts. So to be continued. That is some of the work I'm really interested on working with, and with some of our video interpretation agencies where I feel like they may be having the least amount of access to some training.
Thank you, Liam. I think I can't see anybody else with a question, which allows me to kind of ask a couple of questions, Dr. Sharma, if that's okay. So when we're talking about people whose preferred language isn't English, and then you were doing your presentation, you were talking about the role of culture and navigating the system. It did strike me that it's perhaps what we might call health literacy. So being able to navigate the system, understanding your disease, and how healthcare can potentially prevent deterioration of disease. And I wonder if it's actually those people whose language, preferred language other than English, who have poor health literacy needs, and whether you had in any way formally assessed that, because I know there's health literacy questionnaires, and whether you'd kind of done that before and after your intervention to see whether the intervention improved those health literacy needs.
Yeah, I think that's really an important point. And to me, I think it really gets to the idea of intersectionality as we are thinking about kind of how these different pieces come together. For sure, I will say that this was an area where I think we saw some differences as we were interviewing the interpreters for some of the different languages. For example, our Spanish interpreters talked a lot about health literacy being a major challenge, and the need to, they used the term lower the register, and having to frequently prompt clinicians to kind of lower the register in terms of what we were talking about. So it was interesting how much that theme kind of came up for that group of interpreters. We heard some of that from some of the other interpreters, but not as much. So I think it makes the point that, yes, when you have the combination of a language barrier, cultural norms, potentially low literacy levels, both in terms of health literacy and regular literacy, it makes communication, and when we're talking about communication about difficult topics, so hard. I think it can be challenging sometimes to disentangle which component is driving the issue, but it does highlight that I think that's an important piece that we need to build into as we are thinking about intervention. So for sure, I think one of the ways that the CCMs are really helpful is being able to not just recognize the literacy piece, but then to advocate or educate or intervene on the literacy piece, which I feel like is a little different than some of what we're seeing with our interpreters, which just depends on the person.
It's really interesting, isn't it? It's the language that's used, like lower the register, that the deficit is being placed on those populations, and actually I would say the deficit is on us as healthcare providers, and actually we have inequitable health literacy responsiveness, so we are not responding to their health literacy needs adequately, and actually we need to ensure that all of our resources meet the health literacy needs of these populations. The deficit lies with us, doesn't it?
Yes, I really love that point so much, and I think that's so important. And it's like we know that, and yet we're not fixing it. I don't know. Like, I just think about, we have decades of literature showing that clinicians use a lot of technical jargon, and we're continuing to do that, right? Like, it just highlights how sometimes it is so hard to make change happen, and yet it's so critical.
Well, it's just, using a statistic of you've got 40% chance of recovery. I mean, what does that even mean to the person on the street? We're making great assumptions there around people's health literacy capabilities. And, in the UK, we have an average reading age of 9/10. 10, and then you take all these other factors like culture and everything else into account, and you're actually going to miss a lot of those people. So it's us that I feel need to definitely take some ownership. But I can see another hand up and I need to stop talking. So Siobhan, thank you.
Thank you so much. I just realized I'm coming really close to the time. I just want to say thank you so much. That was so interesting. I'm a pediatrician and I work in inclusion health and do a lot of migrant health, so working with interpreters a lot. One of the questions I had, and I stepped off very quickly to take a phone call, so I hope that you may have answered it already. You talked about the relationship between the CCMs and the patients and how this was this really positive experience. But I was wondering, have you looked at any stage at the relationship between the healthcare provider and the patient and the impact that the CCM has had? I often reflect on my own relationship with patients where there's interpreters involved, and I find sometimes that it can be positive, but sometimes I've had negative experiences sometimes, and that can be because either the interpreter is almost sort of siding with the patient or with me. I sometimes find I'll often use humor in consultations, and sometimes the interpreter will laugh and not interpret the joke because they don't think it's important. And I find it really bothers me because it looks like we're having a joke at someone's expense. So I'm always reminding people, no, you have to translate everything I'm saying or it's really disempowering. I was just wondering, had you any thoughts about that?
Yeah, that's a great question. It made me think about one of the comments from one of the CCMs in an interview we did, where the CCM talked about feeling like we should be at a place where the patient, the CCM, and the provider all feel like we're on the same team. And she was reflecting on how she feels like she and the patient are kind of more closely aligned, but somehow we haven't gotten to a place where it feels like we are all working, right? That we're all on the same team. And so I think it is an interesting reflection on, you can both see how the CCM can build this really strong relationship with the patient, and how does that affect then the provider? And at the same time, as providers, what are the opportunities for us to ensure the patient does feel like we're on the same team? So I think that's such an important point. The other thing it made me think about is that in the data from recorded ICU family meetings, one of the findings was that meeting length was the same, whether the conversation was in English or had an interpreter, because it was all the emotional support and rapport building and a joke that got cut, right? So I think, that was the other thing that kind of came to my mind as you were talking, was thinking about how indeed some of those intentional things we are doing don't get interpreted and then negatively affect the provider-patient relationship.
Thank you, Siobhan. So I can see that the time has hit 5 o'clock, and I personally could continue having this discussion for another hour. So I thank you, Dr. Sharma. And there's lots of comments in the chat about how brilliant and fascinating this talk has been. So there's an evaluation form in the chat, and please do join our mailing list to find out about future events. And our next seminar is the 22nd of January. And thank you again to Dr. Sharma. Thank you, Dr. Sharma, and thank you to everybody for joining today. Thank you.
Yes, thank you all. This was so lovely.
Thank you.